Activity 3, paragraph 1. Point. The research implies a fundamental shift in primary care from reactive treatment to proactive genetic lifestyle screening. Evidence. The primary article proves that 60 minutes of MVPA lowers risk by 9%, especially for those with genetic risk. My secondary research confirms that meeting PA guidelines is a measurable way to reduce incident CHD. Explain. Currently, GP services often wait for symptoms like high blood pressure before intervening. This research implies that services must now integrate polygenic risk scores (PRS) into routine health checks. By identifying high-risk individuals early, practitioners can target resources towards those who benefit most. This reduces the long-term morbidity mentioned in my secondary research, shifting the burden away from expensive secondary care hospitals and into cost-effective community prevention. Link. Therefore, the implications is that primary care must become more data-driven, using genetic insight to prioritize lifestyle interventions. Activity 3, paragraph 2. Point. The research necessitates a redistribution of funding and resources towards community-based physical activity programs rather than pharmaceutical solutions. Evidence. The article states that light physical activity, gentle walking, did not have the same effect as MVPA. My secondary research found that sedentary to vigorous was most effective replacement. Evaluation. This has massive implications for public health in England and local authorities. Funding shouldn't just go forward walking groups but towards active commuting infrastructures and subsidized gym cycling schemes to promote vigorous intensity. If the sector ignores the intensity aspect highlighted in the research, the 9% risk reduction will not be realized, leading to wasted government spending. Providing these facilities in socio-economically deprived areas is crucial to address the wealthier, healthier bias identified in the UK Biobank sample. Link. The research implies that provision must be specific. It is not enough to provide a vigorous activity to be effective. Activity 3, paragraph 3. Recommendation 1. Genetic lifestyle prescription. I recommend that the NHS implement a genetic risk register. Justification. The primary article shows that the high-risk group gains the most from exercise. By targeting this group with personalized exercise prescriptions, we maximize the return on investment for the NHS and directly counter the genetic component people cannot change. Recommendation 2. Workplace health policy reform. I recommend that social care and healthcare sectors mandate activity breaks for staff and patients in sedentary roles. Justification. Both the primary and secondary research highlight that sitting is a standalone risk factor, since modern jobs are increasingly sedentary. Changing the provision of the working environment is justified as a justified way to reduce the 66,000 annual deaths mentioned in the article. Activity 3, paragraph 4. Point. To improve future practice, the provision of research itself must be more inclusive and diverse. Evidence. The article admits that data is from white British participants who are wealthier and in better health than the general population. Evaluation. This is a major implication for health equality. If the NHS bases all its physical activity policies on this study, it may fail minority ethnic groups. Recommendation 1. I recommend that future research funding is ring-fenced for ethnically diverse longitudinal studies. Justification. This is necessary to ensure that provision is generalizable and that the health and social care sector does not unintentionally widen the acts as a blueprint for a more efficient NHS by focusing on intensity, FPA, and genetic PRS as the ancillary replacement. The sector can move from crisis management to precision prevention. The ultimate result of these changes would be a decrease in 66,000 deaths per year and a more sustainable healthcare model.